Welcome to my YouTube channel. Today we're going to talk about low molecular weight heparin, which is under the class of heparins, which is now under the class again of anticoagulants. Kindly make sure you subscribe. It costs you absolutely nothing. Kindly support me as I support your content. As you said before, that the lower molecular weight heparin is an anticoagulant. Let's look briefly at the classifications of anticoagulants. And anticoagulants, these are drugs that prevent further formation of clots. And under the classification, we have indirect thrombin inhibitors, we have direct thrombin inhibitors, and we have vitamin K antagonists. Then under indirect thrombin inhibitors, we have the heparins that we are going to begin with in unfractionated heparin, and then our topic today that is low molecular weight heparin, and then synthetic heparin pentasaccharides, which include fontiparinax, and then we have the new oral administered factor 10A inhibitors, which include rivaroxaban, apixaban, and endoxaban. So among the four of them, the heparins are drugs that are given using syringes. That can be subcutaneous or IV medication, whereas the new oral administered factor XA inhibitors are just given orally. The advantage with the new oral administered factor 10 inhibitors, these are drugs that require little or no monitoring compared to the others, whereas the heparins usually require monitoring. And in case of unfractionated heparin, we're going to monitor using APTT. In case of low molecular weight heparin, you're going to monitor using factor 10XA. You're going to see in the next slide. So indirect thrombin inhibitors, we have agabatron, we have lepiridine, we have bivalirudin, and then we have dabigatran. So among the four of them, the first three are IV medication, while the last is an oral medication. And then the last one is vitamin K antagonist, which we have our good warfarin. And the mode of administration of warfarin is oral. And how do we monitor warfarin? Using INR. So we're going to begin with the heparins. And in terms of the heparins, we're going to begin with the topic of today. Now we have now gone under a smaller classification, that is the heparins. And under the heparins, we have low molecular weight heparin. And in examples, we have enoxaparin, which I said in the previous slide. We have dataparin, we have nadrolparin, we have bemiparin, and satoparin. So in short, we have the parins. So anywhere you see parins, that is low molecular weight heparins. Next, just going to see the characteristics of this low molecular weight heparin in comparison to the other heparins. So in terms of side effects, that is heparin-induced thrombocytopenia and osteoporosis, which are side effects of heparins, low molecular weight heparin has a lower risk of a patient getting heparin-induced thrombocytopenia and osteoporosis. In addition to that, it has limited antagonism of protanine sulfate. So what do we give heparin for? They prevent formation of blood clots. So it is the biggest side effects of giving anticoagulants or of giving heparin is that because they are blood thinners, they can cause the patient to bleed. So in circumstances where you want to antagonize or when you want to reverse the effect of heparin, then in terms of heparin, you give protamine sulfate. However, in low molecular weight heparin, it has limited or partial antagonism of protamine sulfate. And then you usually monitor it using anti-XA. Now and then it is excreted to the kidney. So patients who come in with clearance less than 30 ml per minute, then you just prefer giving them unfractionated heparin, which is excreted by the liver. So unfractionated heparin, it has an increased risk of heparin-induced thrombocytopenia in addition to osteoporosis, and then it has increased reversal by protamine sulfate in comparison to low molecular weight heparin. In addition to that, it is monitored by APTT, and then it is excreted by the liver. So as I said before, if a patient comes in and they have kidney disease, you will prefer giving them unfractionated heparin. So the synthetic heparin, we say the example is fontaparinax, and fontaparinax is a selective antithrombin 3 inhibiting factor XA. So just to inform you, heparins, their mode of actions, which we are going to talk about in the next slide, is inhibiting of antithrombin 3. And then after, for low molecular weight heparin and for the synthetic heparonides, they inhibit and they stimulate antithrombin 3. They don't inhibit, they stimulate antithrombin 3. Therefore, antithrombin 3 there inhibits coagulation factors. For lower molecular weight heparin, it inhibits factor 10A in also for synthetic heparin, heparinoids, it also inhibits factor XA, and it is excreted by liver. So a patient comes in and you have to give heparin. Which one will you choose? Unfractionated heparin. So now let's focus in now on the lower molecular weight heparin, and we said before it's an anticoagulant, and the coagulants, these are drugs that prevent formation of clots or prevent clotting or coagulation of blood. And then low molecular weight heparin, and as I said before, the mode of action, it is what? It inhibits antithrombin. It stimulates antithrombin 3, which now inhibits factor 10A. So it binds to antithrombin 3, and after binding to antithrombin B, it stimulates antithrombin 3, not B, sorry, antithrombin 3, and then later it inhibits factor XA. In addition to that, after inhibiting factor XA, it usually decreases the conversion of prothrombin to thrombin, and later if it decreases the conversion of prothrombin to thrombin, then we will not have fibrin, the conversion of fibrin to fibrinogen to fibrin. So let's just look at this is the secondary hemostasis, which is part of the clotting process. So we usually have the extrinsic pathway and the intrinsic pathway. So we shall just go briefly in the extrinsic path. We usually begin with factor 12, which is converted for factor 12A. Factor 12A usually converts factor 11A to factor 11 to factor 11A, and then factor 11A converts factor 9 to factor 9A, and then factor 9A converts factor 10 to factor 10A. So our low molecular weight heparin stimulate antithrombin 3, which antithrombin 3 goes to inactivate or goes to inhibit factor 10A. So if we inhibit factor 10A, we don't have conversion of, which is involved in the conversion of prothrombin to thrombin. If we don't have the conversion from thrombin to thrombin, then we don't also have conversion of fibrinogen to fibrin. If we don't have conversion for fibrinogen and fibrin, then we don't have formation of a blood clot, and that's why they are called blood thinners. So, as I said before, these are things just a repetition. They are anticoagulants, drugs that help prevent clotting. We already said their mode of action, and then examples we already mentioned, that is enoxaparin, deltaparin, nadoparin, bemiparin, cetoparin. Just to say the parins, sorry. And then the mode of action of administration of low molecular weight heparin is usually subcutaneous, and then it is usually monitored by factor XA. The reason behind this is because, just in briefly, it usually inhibits factor XA. So it is just well for us to monitor low molecular weight heparin using anti-XA or 10A. Clearance usually using RELO. That's why we say patient who comes in with creatinine clearance less than 30 ml per minute, we usually prefer giving them unfractionated heparin. And then antidote is usually protamine sulfate, which is partial reversal, and then it has a higher bioavailability compared to unfractionated heparin. In addition to that, it has a longer half-life, 2 to times 3 normal that of unfractionated heparin. So in terms where you have to give the patient for longer periods, then we'll prefer low molecular weight heparin. However, when the patient you have to give the anticoagulant, they're going to surgery after 2 days, then you have to convert them to unfractionated heparin because of easier monitoring and of easier antidote, that is easier reversal, which we say it has better reversal than low molecular weight heparin.